So we all know this, osteoarthritis is a result of biological and mechanical events, and we usually see this medial compartment. Talking to Dr. Gaurav Gupta as well, that there are some patients who come across to us and they say, डॉक्टर साहब घुटना तो नहीं बदलवाना, क्यों नहीं बदलवाना? पता नहीं, हमारे कोई मरीज ने ऑपरेशन कराया था और उसके बाद वो उठ ही नहीं पाए. So I'm yet to see, where these patients get operated or how such dreaded complication can occur. But I think that's not the topic right now. So how many of the people among the people who are just listening, they use bone grafting in their ITP osteotomies? Okay. I know Dr. Gaurav Gupta does not use it because we were talking about this recently. So as if you require correction which is greater than 10 degrees, or as Dr. Himanshu just said, it's 12 degrees, then bone grafting is advisable. If it's a young patient and the correction is not so much because we know that he's presented early, not very obese. Yes, even meta-analysis and all this show that bone grafting is not needed. So, in case we are using a bone graft, I always use a bone graft for all my osteotomies. This is just the part where how we harvest our bone graft. We use it from the iliac crest to buccal. We sometimes do both sides osteotomy as well, so we can take the graft from the same side iliac crest, and then use the bone wax track to drain deep closure and skin closure. I prefer the four osteotome bone graft harvesting technique. This is just a photograph. So these are four osteotomes. It's a little difficult to appreciate, because of the way the photograph has been taken. So first of all, I'd like to just use these four osteotomes, which are usually standardly 35 mm, 20 mm, 10 and 15 mm. Use the periosteal elevator and the cautery with the help of a sharp towel clip to allow easier delivery of the graft. And you can see that we always try to avoid any piercing of the inner table of the pelvis. So this is how the trapezoidal graft which we usually harvest. You can see that this is a trapezoidal in shape, and this is all we've already planned how much of the bone graft we will be needing to put in our osteotomy site. This is the surface marking as we're about to start the procedure. Better to mark so we can have a easier surgery. We like to put a bolster or roll towels underneath the knee before making the incision. The skin incisions, well, a lot of people like to use some people use vertical incision, some people like oblique incision, some people like to use inverted L incision. We were initially doing inverted L shaped incisions, but we found that they were having some soft tissue problems, at least by the time when I joined my father. Then we have recently switched over to more of vertical and between the vertical and the oblique incision. After that, as soon as the incision is made, we find the pes sensoriness, and then we release the superficial MCL. This is very important that you have to release the superficial MCL, because without releasing the superficial MCL, the unloading of the medial compartment does not take place, so it is very necessary. A lot of people, what we do is the next step is we do some finger dissection on the posterior side of the tibiofibular joint. If you don't want to go to the tibiofibular joint, you can just place a Bowman. The purpose of this is that ultimately we want to save the neurovascular structures which are at the posterior part of the tibia. So the first thing with what we do is we put a KY with the first KY is parallel to the joint line. The second and the third are at a desired angle, but proximal to the tibial tuberosity. The osteotomy level is preferably parallel to the joint. Osteotomy is usually started with a saw, and it is to be completed by osteotome. We have to be mindful of the common peroneal nerve to prevent the injury. Some sets, they also have radiolucent posterior retractor, and you can place it all the way posterior. We don't have it. so we just use a conventional movement. And I also do not typically go all the way posteriorly to see the structures. I was recently talking to my senior. He said that he likes to do it that way so that he's very sure that he does not invade the posterior structures. So the parallel two guide wires are put and they are shot at the head of the fibula. So again, the common problems which we usually face in high tibial osteotomy is sometimes this fibular head is too proximal. So what I mean to say is that sometimes the distance between the lateral joint line and the head of the fibula is very short, and we must be mindful of that and not exactly aim at the head of the fibula, because we might end up creating an interarticular fracture. Another parallel guide wire is put. Now there is a new concept of retrograde hinge wire. There have been some meta-analysis which say that there are almost around 20% fractures which occur which are not visible on the C-arm, and this is a post surgery. They have seen some CT scans in their patients. So a lot of people have started to put this retrograde hinge wire. And what they say about this retrograde hinge wire is that basically, as we all know that our high tibial osteotomy, it relies on an intact lateral hinge. And if there is a fracture which progresses from this point, so they've basically classified that if it goes at the level of the tibiofibular joint, it is number 1, and if it is distal to the tibiofibular joint, it's 2, and if it progresses proximally, it's an intra-articular fracture, and that usually can lead to a problem. So at this time, a lot of people have started to put this hinge wire, and they say that this hinge wire this prevents the progression of a hinge fracture, and it protects the hinge. I don't usually use this hinge wire in my practice. We used this saw before the saw was not easily available. We used to struggle with just the osteotome, especially the posterior cortex, but the saw has made our life much more easier. And as Dr. Varshini has rightly pointed out, because we've already planned, we know the width of how much the saw has to go inside. So before we actually use a saw, one tip which I think all of the surgeons which have been doing high tibial osteotomy is that we usually try to flex our knee. By flexing the knee, the structures, they go a little posterior, and you also always have a Homan retractor to protect them. A lot of people, they do a biplanar osteotomy, especially if the deformity is large. Then we use these chisels. The chisels are just sort of stacking among each other, and then we try to increase the size of the osteotomy, and we see that ultimately there is a trapezoidal gap which is formed, and in this we use the laminar spreader. As posterior, if we go very posterior just and apply our laminar spreader, there is not much increase in the slope, as Dr. Gaurav Gupta was saying that there's an increase in the decrease in the tibial slope, or how do we manage it. But I think that is one reason why a lot of surgeons who used to do lateral based closed wedge osteotomies, they shifted over to open wedge osteotomies, because this relatively takes care of this problem of tibial slope. So the placement of the graft, as I said, we use a trapezoidal graft, and the distal tibia is to be kept in valgus extension and external rotation sometimes, and this device, this comes in our Tomofix set. This makes our correction more predictable, especially as we were just, the last question came that, there may be a deviation of 2 to 3 degrees, then how do we take care of it? So because this device has degrees which are mentioned on this, this makes it a little easier for us to decide that the level of opening which we are making in a high tibial osteotomy, is it adequate, and obviously we'll be putting a graft inside this. Then the Tomofix plate, it comes, it has 4 holes in the proximal segment, and then 4 holes in the distal segment. They're all labeled 1, 2, 3, 4, and then A, B, C, D. And accordingly, we put our first screws in the proximal fragment. After we put our screws in the proximal fragment and then fix the plate and our osteotomy, we usually try to remove this device, which I said, because it interferes in the positioning of the plate. And as Dr. Himanshu had rightly pointed out, that in order to just see how much opening we need and subsequently fix with a graft or without a graft, is that we take our ruler. We have the metal rulers, or you can use the paper rulers which are sterile, and then we mark the posterior part, or 2 parts. One is in the posterior, in the proximal fragment of the tibia, and also in the distal part of the tibia. We mark 2 points, and then we just see that we after measuring it, we see that with the scale also, when we put our laminar spreader, it should be maintained in the same with the same distance, because otherwise we can have loss of correction. Initially, a long time back, when locking plates were not very popular, we used to use these non-locking plates, but then they had the problem of contouring, and for that we needed the bending press, and because Tomofix was not very easily available, this was the plate which we initially used to use probably around 10 years back. The placement of especially these locking plates, if you don't use the conventional Tomofix plate, is that it should be as posterior as possible. And sometimes the technical problem of using these plates, if you're not using the Tomofix plate, is that it's difficult to conform to the shape of the proximal tibia. We usually use the lateral opposite side lateral tibial buttress plate. So fixation methods can change. But I think nowadays it's more popular to use the Tomofix plate. In these locking plates, as I've said, we try to have a contact of the plate as wide as possible and try to place it as posterior as possible. We've recently started using these lateral head tibial locking plates because it's a fixed angle device, and it leads to less screw backing out. Still, if you don't have any ways, we still use the cautery wire, and as sir has rightly pointed out, because the patient is in lying down position, it may not be very accurate, but maybe it can give some fair amount of hint as to how much correction we have achieved. This is just a video of of the surgical steps, and these are just some C-arm shots of the various steps which we usually take. The laminar spreader is placed posteriorly. We place in the bone graft and subsequently stabilize it with a plate. So the longest follow-up which we have is almost 14 years. So this lady, she was operated in 2010. You can see she has gross varus. In fact, this was done as a staged procedure for her varus correction. But ultimately, she just came to us, I think it's written 24th July 2024. She was satisfied with her knees, but came because of an osteoporotic fracture. So just in the end, I would just like to conclude that a high tibial osteotomy, if it is selected in a very proper way and done in a proper way, it lasts quite decent in a quite decent way. There are a lot of our Indian patients, who are not willing for total knee replacement. It is financially a significantly cheaper option, and particularly in Asian countries where squatting and cross-legged knee activities are required in their day-to-day life. We must be cautious about that we don't undermine the skin a lot, because wound complications is a disastrous problem in high tibial osteotomy also, and we must be careful that we don't want to go intra-articular while we're trying to maintain that lateral hinge, and sometimes the lateral hinge, if it gets fractured, your osteotomy becomes unstable, it becomes quite difficult. And even though we are sometimes using a vertical incision, we can go a little high, but we must be careful that we do not breach the joint, because if the synovial fluid starts leaking, it can lead to wound healing and delayed healing of the osteotomy as well. I thank you all for a patient hearing. Thank you very much.
Thank you, Dr. Gaurav. Now next talk is Dr. Himanshu.